Hi, everybody. We're just going to wait a few more minutes to see, let people join, and then we'll get started. Once the numbers in the participants box stops going up, we'll leave it a minute or two. So I think we've given it a couple of minutes. We'll start there. So I want to welcome everybody so much for joining us this evening to talk about this important topic, which we think is important. We will start with a few messages from the British Pain Society. So this webinar is kindly hosted by the British Pain Society, which is our specialist organisation, and they have given us a couple of slides to share. The topic we're going to discuss, as you know, is the menopause and perimenopause and pain. And really, I'll present an overview initially, and then we will take some conversation or some messages in the chat box towards the end. So do put them in as you go along, and then we will address each of those as we can, depending on the number of messages we get. But this is a slide summarising the British Pain Society. And on the next slide, we have the rules. So we put your questions in the chat box. We are being recorded, and the webinar recording will be saved on the BPS YouTube channel. So it is available for other people to access if they can't join us this evening, so after a busy day of work. And then afterwards, the BPS Secretariat will send you an evaluation form with a few questions just to let us know how it went and how you found it. And you'll get a link for that. And once you've done that, then you get your certificate. So it's a trigger to get you to answer some questions. The annual scientific meeting is coming up 4th to the 6th of June in Nottingham, and before that there's on the 3rd of June there's a study day. There's the advert for it. I hope everybody can come and enjoy it and learn some stuff. So with that, I'm briefly going to share a couple of slides, but really with the increasing awareness and conversation in the community about the impact and management of the menopause, it was something that I found I wanted to learn more about and understand if there was anything that could be of relevance to our patients with chronic pain and presenting to the pain clinic. And obviously our experience and literature shows that there is a high proportion of middle-aged women presenting to pain clinics. So I attended a confidence in the menopause training course and was really struck by how the presentation of the menopause matched so much with what I was seeing in a chronic pain clinic and labeling as chronic widespread pain or fibromyalgia, similar symptoms. But when it was being presented in a menopause context, was being seen as the menopause or the perimenopause. And felt that it was really important for us to understand as clinicians working with these women what else was in their makeup and their background and what else might be going on for them and how best to support and signpost them. And find that there's two groups of people really. There's some people who are very aware of it and very alive to it and might come with questions, and so it's helpful for me to have some sense of what we're talking about. There's another group of people who really aren't alive to it, aren't aware of the impact of the menopause. They're not thinking about it. They're not raising it with their GP. And for those people, I think sometimes it's really useful to bring that into the conversation, be able to have some informed knowledge about what the impact of the menopause is and how to signpost people. We did a brief, sorry, I'm just trying to share at the same time, review of our referrals into our Camden Pain service of over a 3-month period, and this was our numbers. So in this bar, the darker bar, is the number of females, and obviously presenting to an MSK community pain clinic, a heavy preponderance of people between 40 and 59 who are female. And I think that really speaks to how this overlap is happening. So here's a brief summary of what we are going to cover today. And I hope it's of interest, and please, as I say, do put your questions in towards the end. So we have with us Dr. Jane Robertson, who will introduce herself shortly, and then Catherine Borra, who are going to give us some talks about the area. So Jane, if you wanted to introduce yourself and then carry on with your talk.
Yes, sure. So good evening, everyone, and thank you very much for inviting me, Lucy. I was a GP for many years, until about 18 months ago, but while working as a GP, developed a special interest in perimenopause and menopause. Sorry, did I say, yes, I'm Dr. Jane Robertson. I might have missed that bit out at the beginning. And Lucy and I go a long way back. We were medical house office together back in Cheltenham many moons ago now, and but yes, for the last 3 years I have worked at Newson Health, which is a private menopause clinic in Stratford. This evening I am not representing the company, I'm speaking independently, but yes, that's where I work and have worked there for 3 years as a menopause specialist. Catherine, did you want to introduce yourself now, or shall I carry on with my slides?
Maybe you carry on and I'll introduce myself later. Thanks.
Okay, so I will just share. Bear with. This is always the tricky bit, isn't it? There we go. And yes, hopefully everybody can see the slides. So,
yeah, right.
Okay, brilliant. So the overview that I thought may be helpful is to talk about the symptoms of perimenopause and menopause, and to do some myth busting, and to also talk about the management, which will include just some information about HRT. And I completely agree with what Lucy has said so far. Certainly in my clinical experience, many women are presenting with joint aches and pains in particular, as part of their presenting symptoms, and many women will have been diagnosed with fibromyalgia. So I think it is a very interesting area, with much crossover, as we've already, as Lucy's already alluded to. So what is the menopause? I'm teaching grandmas to suck eggs, I'm sure, but I thought it was useful to have an overview. So it's when periods and menstruation stop, and the average age in the UK is 51. So this is the menopause itself, and it's usually classified that you're in the menopause when you haven't had a period for 12 months. And so the range of age that the actual menopause can happen is between 45 and 55. We would class it as an early menopause if this happens before the age of 45, and there is a separate clinical condition, premature ovarian insufficiency, or POI, which is when a woman will become menopausal under the age of 40. Now, perimenopause is the time leading up to menopause. For some women, this will be 1 to 2 years, but for other women, this can be 8 to 10 years. So if we do the maths, we can see that in one's early 40s, women can become perimenopausal. This is just a reminder about ovarian hormones at different times of life, and the top graph in red is estradiol and the blue is progesterone. And we can see that in the perimenopause, there are huge fluctuations in estradiol with a downward trend. And it is these fluctuations and the decrease in the estradiol that will often be causing the very troublesome symptoms. Some fluctuations continue in menopause, but to a lesser degree. And by then, the estradiol levels are really quite reduced. So, as I'm sure you know, we have estrogen receptors in many, pretty much every part of our body. And this is just a reminder of that. So brain, heart, liver and bones, which is particularly important, of course, from the pain point of view, and of course, skin as well. And we're beginning now to think really of the menopause as a long-term chronic hormone deficiency, similar perhaps to, hypothyroidism. And who is affected by the menopause and symptoms? So we'll sort of use the word menopause and perimenopause interchangeably in some respects. So about 80% of women will have symptoms. This was a survey that was done by Newson Health. 25% of women will have severe symptoms, and 25% of women will need to take some time off work. And up to 20% may change or leave their jobs. And 3/4 of women did not realise that sort of the majority of their symptoms were due to menopause. So that's very interesting. So a little bit of history. As we've said, the average age is 51, but of course back in many years ago, life expectancy was only 51. So nowadays, with life expectancy of 82, and I suspect it may be slightly higher now, we can be looking at spending 1/3 of our lives post-menopausal, and that's why it is a particularly important subject. So what are the symptoms? Many of these you will know, and perhaps some may come as a little bit of a surprise. So I'm going to talk about the physical symptoms and then the psychological symptoms. So obviously the one that everybody knows is hot flushes and night sweats, poor sleep, fatigue, and particularly in the perimenopause, periods will change quite significantly for a lot of women, as well as becoming more spread out. Actually, periods can become more frequent, and they can certainly be very heavy and painful before they then begin to lighten off and stop. And joint and muscle pains. Before I did a lot of work in menopause, I really hadn't understood how prominent joint and muscle pains are as symptoms, and people talk about feeling like a tin man and very stiff going downstairs, and having soft tissue injuries that just won't sort of heal. That's a very common thing that people say, and obviously we can see some overlap there. Headaches, weight gain, and then more localized symptoms, vaginal dryness and soreness, and urinary symptoms, including frequency, urgency, and leakage, and of course, reduced libido. That can be in itself a symptom, but of course can be related to tiredness and weight gain and poor sleep. So psychological symptoms are hugely variable, and often actually are much more troublesome for women than the physical symptoms in some respects. And of course, like women with chronic pain, low mood is a very common symptom. also anxiety, worsening PMT, and some women who've never had premenstrual tension in their lives will suddenly start noticing real mood changes before their periods, and irritability with family, people in a car park, co-workers can be a very prominent symptom. And women describe rage, just red mist that comes down that they've never experienced before. Brain fog, and this can include poor memory, poor concentration, and this can cause people to, lose confidence at work, and it can affect their self-esteem, of course, and also just a loss of interest in socializing and being motivated to exercise or eat healthily, and just feeling overwhelmed and not able to multitask anymore is a very common symptom. So these are symptoms that I thought it might be interesting to list that actually may not be as easily recognized as being related to the perimenopause or menopause. Dry, itchy skin, pins and needles is a very common presenting symptom, and electric shock type sensations. People describe feeling jittery or shaky on the inside, restless legs, burning mouth. And of course, I would, as part of fibromyalgia and pain, women can be getting such symptoms, can't they? Such as pins and needles and sort of shock sensations. But also, yes, burning mouth, tinnitus, gum disease, dry eyes, hair thinning, and palpitations. Many women have been referred to a cardiologist by the time I see them in clinic, or to ENT about their tinnitus. So how long can menopausal symptoms last? And again, this is very variable, as you can see. But yes, 1 in 10 women will experience symptoms for up to 12 years, which is obviously a long time to be putting up with symptoms. And so what are the risks to health with the deteriorating, lowering estrogen levels? We think about, of course, bone thinning, which obviously can result in osteopenia or osteoporosis and fractures, central obesity, raised cholesterol, and cardiovascular complications. Also dementia and depression. And of course, with chronic pain, many women will be suffering with depression as well. So how can women manage their symptoms? I think more and more women are speaking to each other and are feeling much more open and able to talk about their symptoms, both socially with their girlfriends, but also perhaps in the workplace as well. And I think luckily nowadays there is a lot more information out there for women. There are many, many podcasts, and of course Davina McCall has done a couple of programs on Channel 4, and it very much in the press and on social media, isn't it, on This Morning? And so there is a lot of information. Of course, there is misinformation as well, but I think that women will find that they can deal with things better if they feel a little bit more informed. And I often have patients who say, I didn't click, I didn't realize I was perimenopausal until I listened to that podcast, and then I could tick every symptom and the penny dropped. I realized what was going on. And of course, some people will be able to talk to their mothers or aunts or cousins, but other people won't be able to. And I'll come on to explain more about lifestyle issues that can help, and alternatives to HRT, and some information about HRT. So with lifestyle changes, there's no doubt that increasing exercise and eating a healthier diet can be very helpful. Stopping smoking can reduce hot sweats and night sweats, and reducing alcohol. Now, of course, this is all very, great on paper, but when women are feeling low, anxious, tired, fatigued, it can be extremely difficult to be making healthy eating choices and to be exercising as much as they should. And then, of course, there's the guilt that comes with that. And also alcohol. Many women are using alcohol at this time of life, actually drinking more alcohol rather than less, to to help them feel better in the short term, or in fact to help sleep, of course. And I would imagine, Lucy, you can, I'm sure you may have seen that, I presume people will also use alcohol to help with their pain sometimes, very much so, as well as other chemicals. So yeah, it's important to have calcium and vitamin D at this time of life for the bone protection. And yes, again, very theoretical to say try and sleep well and relax, but of course that can be very difficult at this time of life with symptoms. So there are many alternatives to HRT that are available, and you only have to walk into Boots nowadays to see great big marketing about this vitamin is going to change your life and going to make everything better. And of course, many of these are not evidence-based and are profit-driven rather than evidence-driven. And yes, things like red clover and black cohosh, I think people assume that they're safer because they're herbal, but we know that black cohosh can actually cause some liver issues. One difference to point out, I think, that people will sometimes talk about bioidentical hormones. I will be discussing body-identical hormones, body-identical HRT, bioidentical hormones, and there are many private practices that prescribe. These are more bespoke by creams and forms of HRT, but these are not regulated and are not don't have so much evidence base behind them. So I think that can be very confusing for women, but we certainly don't we wouldn't particularly advocate the use of bioidentical hormones, although I'm sure they will work for some women. But yeah, I think the safety and the regulation is quite different. So if we have a brief sort of look at HRT, much of this that you will know. So the main hormone that we treat women with is estrogen. And if women have their womb, they will need to have progesterone as well to protect the womb lining from thickening. If you give unopposed estrogen, there is a risk that the womb lining can thicken. If women have had a hysterectomy, they don't require estrogen. So there is all manner of types of HRT. In the old days, oral pills were much more commonly prescribed. Nowadays, we would tend to use patches and gels and spray, and I'll go on to why the transdermal route is safer. One way of having your progesterone is via a Mirena coil, and that can be a very convenient way of having the progesterone that a woman needs because they are fitted and last for 5 years. So what does body identical mean? It means that the estrogen and the progesterone are the same as our own natural hormones. Both the progesterone and the estrogen are derived from the yam vegetable. And so they actually are, a very natural product in many ways. There is systemic HRT, of course, which is what we're sort of talking about with the progesterone and the estrogen, but localized estrogen, such as Vagifem pessaries or Ovaston cream, can be extremely helpful for vulval and vaginal symptoms. We're really recognizing now the importance of testosterone for women as part of HRT. It is still quite difficult. Many clinicians and GPs have not had education about prescribing testosterone, and so it can be a real postcode lottery for women as to whether they can be prescribed testosterone by their GP or not. But I think this is slowly changing. The typical symptom, people think that testosterone will help with his libido, which of course it can do, but there is increasing evidence about how much it can help with energy levels, cognition, and also muscle stamina, muscle weakness, and muscle strength, and also mood and anxiety. So it really does have a role alongside HRT. And yeah, those are obviously all the varieties. So the main body identical progesterone that we use is pictured there is called Utrogestan, sometimes known as Gepratix, which is a new brand of Utrogestan. Just to clarify, the progesterone in the Mirena coil is a synthetic progesterone, but it is, because it is so low dose and it's absorbed locally, it is classed as being as safe as body identical progesterone. So why is transdermal estrogen so safe, and why do we use it now? So as we've said, in the old days, the oral estrogens that we used were synthetic. The transdermal patches and gel and spray that we have now really are very safe and can be used for women that traditionally we would think would not be safe to have HRT. And this is because that they are absorbed directly in the bloodstream, bypassing the liver, and so there's no effect on clotting factors, and therefore no increased risk of blood clot or stroke. So these patches and gels and spray can be used if you have a personal or a family history of blood clot, for example, history of migraine, hypertension, or obese women. Oral Utrogestan, the progesterone, is also safe in these circumstances. And so that's a huge sea change from older oral synthetic estrogen and progesterone. And I think that's probably the area where there is most confusion for some clinicians and GPs who haven't been able to update their knowledge, that this is a very big difference in practice, and we can be very reassured about the safety. So what are the benefits of HRT? Obviously, one of the most important thing for patients is improving symptoms and improving their quality of life. But we have very large amounts of good quality evidence now that body identical HRT reduces risks of osteoporosis, reduces cholesterol, and lowers risk of diabetes and heart disease, and reduces dementia. There is also some evidence that it may reduce the risks of colorectal cancer as well. So one of the most controversial areas has been about breast cancer, of course, and the use of HRT, and this is what puts a lot of women off. And this, dates back to the WHI study back in the 1990s and the Million Women study that was in 2003, much of which has now been discounted and in fact was based on oral estrogen and synthetic progesterone, so clearly very different preparations to what we use nowadays. We have to remember, of course, that breast cancer is common. 1 in 7, 1 in 8 women will get breast cancer, and this increases with obviously increasing age and family history, but also obesity and alcohol and lack of exercise are very significant risk factors for breast cancer. So what can we say about breast cancer and the use of body identical HRT? So all the evidence to date with body identical HRT does not show a statistically significant increased risk of breast cancer. And there is sort of studies that are ongoing and new evidence coming out all the time. Women who have had a hysterectomy and have estrogen-only HRT, even back in the those early trials, evidence actually showed that the estrogen-only arms showed a reduction in risk of breast cancer. So when we think back, the possible small increased risk of breast cancer with HRT use is with longer term use of older synthetic types of progestogens. And so that we can be very reassuring for patients about that nowadays. And for example, women who have a family history of breast cancer, what we tend to say is that going on to HRT, they have their existing risk of breast cancer, but going on to body identical HRT is not increasing their risk any further of breast cancer. And yeah, that's me done. And I'm obviously be very open to questions at the end. And thank you once again for listening.
Thank you so much, Jane, for that really great overview of the topic and helping us understand how identification and what the options are for people. And I think that safety element is really helpful for us to have a handle on. I think one of the things that I see is sometimes people are nicely stable on their HRT and then get a DVT or something, and they get whipped off their HRT and then end up in my clinic. I have made contact with our haemophilia teams in the past, and it's been really useful to know that really the transdermal formulations are not a risk. So I'm going to hand over to Catherine, who I'm sorry I didn't give us an opportunity to introduce at the start. I'm sorry about that. Do introduce yourself, Catherine, and let us know and who you are and what you're going to speak about.
Hi everyone, and thanks so much Lucy and British Pain Society for inviting me this evening. I'm Catherine Borra. I'm a doctoral researcher at UCL, and I'm a research associate at Barts Health NHS Trust in London. Before I start, I want to just acknowledge my funders, the ESRC and BBSRC, without whose support I wouldn't be here today to talk about my research on the intersections of chronic pain and the perimenopause. So that's my topic tonight, and that's the topic of my doctoral work too. So my interest in this topic comes from when I was working as a physiotherapist in both an NHS pain management service and a pelvic health service, and started noticing the overlaps between different clinical populations. Now, there are various ways or layers of analyzing the intersection between pain and perimenopause, and I think clinically there's a lot of symptomatology overlap between the two, as Jane was telling us about, and from Lucy's experience too. But at the same time, there are a lot of narratives throughout the life course which contribute to different chronic pain and perimenopause experiences. So things like gynecological histories, pain histories, health conditions, social factors, beliefs, etc., that suggest ways in which the social world gets under women's skin, and conversely how organic presentations then affect people's lives. So really I'm interested in how things don't really happen in isolation and happen on a continuum as well. So this evening I'll present to you some early findings from both quantitative and qualitative work that hopefully the clinicians amongst you will find relevant to clinical practice, and for patients or people who are experiencing pain or the menopause might feel familiar. So I'll start with a brief overview of existing literature, a little bit to complement what Jane was talking about. So in terms of literature around the intersection of chronic pain and menopause, there's little that has been published. So a recent quick scoping review showed only 197 records, and this was through a keyword search on Web of Science. And the positive thing, I guess, is that the results do show an increase in interest in the topic in recent years, with most of the articles having been published in the last few years. So the articles resulting from this search are literature reviews, observational studies, and a proliferation of opinion pieces and commentaries, really with quite varying quality and pertinence. Most are published in gynecological related journals, with some in rheumatology, and I think this really manifests this attention given to the intersection of menopause and fibromyalgia in particular. But I guess a big point of note from the scoping review is the heterogeneity of menopause definitions. So Jane gave us a great overview of, the pre-menopause, perimenopause, postmenopause, and the different stages of that. Whereas in existing literature, especially older literature, there's all kinds of definitions being used, which makes it difficult to compare findings amongst studies. So to draw on two areas of existing publications on this topic, in terms of describing the overlap between perimenopause and pain symptoms, there are a few important insights, and I'd like to flag the work of Caroline Gibson et al. From 2019, who show how in a sample of veterans, women with menopause symptoms were 84% more likely to have chronic pain compared to those who didn't. So this is telling us a little bit about the prevalence of pain within the menopause and perimenopause cohort. From an intervention perspective, we know the role of HRT in the management of menopause symptoms. In this particular intersection with chronic pain, the literature is highly heterogeneous. So a lot of the interventions that are mentioned encompass studies of exercise, complementary therapies, HRTs, and the studies tend to be quite small, with the largest studies being observational studies that might be looking at the relationship between HRT prescription and chronic pain, but can really be misleading because they're not looking at the reasons for these associations. So if you're interested in sex hormones and pain, I'd really like to refer you to an excellent review paper by Gulati et al. From last year in, I think it was Lancet Rheumatology, which is about sex hormones, musculoskeletal pain, and osteoarthritis, and reviews trials of hormone therapy relevant to pain, although not necessarily chronic pain and the perimenopause, but lots of good clinical insights from there. So because of the relative paucity of information about chronic pain and the perimenopause, with my PhD, I took a step back from intervention and focused on the overlap between chronic pain and perimenopause symptoms to try and understand how they present, how they might look like in a clinic, for example, and hopefully in an effort to lead to better understanding of what the next steps need to look like from an interventional perspective for this cohort. So I'll present some early results from a recent study of a population representative sample, which aimed at identifying pain and perimenopause symptom trends within the population. So for this study, we used data from the National Child Development Study, which is a birth cohort study of people from the UK born during 1 week in 1958, and for whom we have strong longitudinal data. For this particular study, we used a sample of 4,303 females for whom we had outcomes around the presence of chronic pain and chronic widespread pain at age 44, and who'd answered a menopause symptom questionnaire at age 50, and for whom we had menopause status data as well. So in terms of how we defined the chronic pain variables, chronic pain itself was defined by participants answering affirmatively to whether they had pain lasting for 3 months or longer, and it was categorized as chronic widespread pain by looking at a body map of pain locations that they'd filled in and using the American College of Rheumatology definition of fibromyalgia. So we looked at presence of contralateral upper and lower quadrant pain and the presence of spinal pain at the same time. So within our sample, by age 50, 25% of participants were premenopausal, 43% were perimenopausal, and 27% were postmenopausal. The remaining minority having gone through surgical menopause. Now, when we started looking at our data, as expected, we noted that some symptoms like sleep problems or psychological issues like anxiety and depression, which can be related to both chronic pain and menopause, were higher in the chronic pain categories. So in each chart, the top bar stands for no symptoms, whereas the lower ones represent the proportion of people who did experience symptoms. So if we look at the first row for sleep problems, you can see that while in the no chronic pain group, sleep problems are about 50-50, they are prevalent in over 60% of people with chronic pain. But we also noted that other symptoms like vasomotor symptoms, which included hot flushes and night sweats, which are traditionally associated with menopause, and others, urogynecological issues like painful sex, urinary frequency or incontinence, vaginal dryness. These are menopause symptoms described by Jane. They were also more prevalent in women or people with chronic pain. And within these prevalence values, there will definitely be some various combinations, with some people experiencing some symptoms and not others, and differing experiences of overall menopause, with some participants having an easier time and others having more struggles. So this really led us to ask how these symptoms clustered and presented within our sample, within this group of women, or better, if there were particular groupings of menopause symptoms which could tell us about different experiences of menopause, regardless of chronic pain, but then also to see how chronic pain related to these groupings and various menopause experiences. So to answer these questions, we ran a latent class analysis, which is a statistical technique which identifies underlying unifying traits within a population. And we ran this on the sample that I described, and looking at 19 different menopause symptoms within this questionnaire that they were asked at age 50. And this included a variety of somatic symptoms, so things like aches and pains, vasomotor symptoms, hot flushes, urogynecological symptoms, sleep issues, psychological and emotional symptoms. And throughout the results, we identified 4 classes or 4 groups, which I'll describe now. The first class represents the least problematic menopause experience from a symptom perspective, in which participants are united by having relatively low probability of most symptoms, although of course some things are more prevalent than others. We see aches and joint aches and pains being a bit ubiquitous throughout the different classes. The second class represents a menopause experience dominated by vasomotor symptoms, so hot flushes, night sweats, with concomitant moderate sleep issues, aches, again ubiquitous, and some psychological symptoms, while the probability of other symptoms remains relatively low. The third class identifies menopause experience characterized by psychological problems. So all these ones at the right, so things like forgetfulness, sleep problems, anxiety, depression, irritability, etc. Again, together with sleep and aches as well. And finally, the fourth class shows us possibly the worst menopause experience, where the margins for all symptoms are high, and over 80% for aches, vasomotor symptoms, sleep, psychological symptoms, as well as quite a high probability of other symptoms like other somatic and urogynecological symptoms. So you see that these groupings help us understand how much better the menopause profiles of different subgroups, basically how different people in our menopause population might be presenting, and the variation in experience. So we then added on chronic pain to see how these people with chronic pain are represented in these different classes or these different groups. So in this slide, you can see here that people with no chronic pain were most likely to be in the low symptom group. So followed by the vasomotor group, the second line, psychological, the third line, and only a minority were in the high symptom burden group. For those with chronic pain, the likelihood was reversed. So you see the inverse trend, if you like. You can see here that over 30% of females with chronic pain were in the high symptom group, and only a minority experienced few bothersome symptoms. When looking at widespread chronic pain, those with none were distributed more or less evenly between the first and the second class. But when looking at those with chronic widespread pain, about 50% were in the fourth class. So we're looking at high likelihoods of sleep, psychological issues, vasomotor issues, urogynecological issues, and other somatic symptoms in females presenting with widespread chronic pain. Now, this tells us a little bit about the complexity of presentation of this caseload in the clinical environment, you know, with bothersome symptoms leading to various and spurious needs, and quite difficult to manage for the clinician. Now, chronic pain and chronic widespread pain, these two variables were measured at age 44, and I just want to reiterate that because it's telling us about the experience of symptoms of that women with these conditions might go on to have, as well as have as their pain arises. So I guess the key insights from my perspective for this work are that females with a history of chronic pain are more likely to experience a wide range of bothersome symptoms associated with the menopause. And the clinical prompts that derive from this are: what is the optimal management of menopause symptoms to improve patient burden in this group? And what does optimal management look like for individuals? I'd like to conclude by telling you a little bit, well, by adding patient voices to the picture and talk about findings from a qualitative study of women with chronic pain over the perimenopause period. This was an ethnographic study that we conducted, so a kind of a in-depth multimodal qualitative study of 20 women aged 40 to 65, who we interviewed on 3 separate occasions, exploring gynecological and social histories, experiences of pain, menopause, the way they navigate life, the way symptoms affect their activities, their healthcare experience. And we carried on engagement with a subsample of this group for over 4 months to gain more in-depth information. Transcripts were analyzed thematically and coded and presented into themes. Now, just to give you a brief overview of what this sample of 20 participants looked like. A lot of the participants had chronic widespread pain or chronic pain, but the chronic pain group itself, it seldom was pain in just one location. It often was in 2 or 3 locations, but not making it to the chronic widespread pain definition, or sequential pain, so pain first in one joint, then in the other, repetitive tendinopathies and chronicities over the arc of the perimenopause. It's also notable that around half of the participants had had chronic pain prior to the perimenopause, but experienced a worsening of these symptoms during the perimenopause. And in terms of menopause symptoms, they presented with a variety of issues. A lot of them reported psychological issues and issues like fatigue that were not in the menopause questionnaire from our quantitative study, but is definitely a big feature of in this group. So if I wanted to try and box the participants of the study within the classes from the previous study, I'd say that over 60% belonged to class 4, so high menopause symptom burden. Now, we're still analyzing the wealth of data produced by these interviews, so I'm going to limit myself to some insights that are hopefully the most pertinent to tonight. The first is around symptom confusion. Now, overall, when speaking of their pain and perimenopause experiences, participants reported struggling to qualify the relationship between symptoms and understanding what belonged to what. So a common example was that triangular relationship between poor sleep, pain, and irritability, where pain and sleep have a kind of circular relationship, with one triggering the other, and perimenopause worsening that relationship and then having an impact on mood during the waking hours. Now, a common sentence from participants was, I didn't know if this was my pain or if it was menopause. How do I tell? Signifying that difficulty in meaning making and ascribing a value to pain, which is particularly difficult in this period of life compared to other periods that are also defined by gynecological events or changes like menarche or pregnancy, where pain has a specific etiology, a specific meaning, rationale, and also time frame. While some pain was a feature of the perimenopause, whether it was interpreted as such at the time, it really varied. And for the majority, the perimenopause acted as I said, as an amplifier of pain, making it harder to either manage existing pain or the overall menopause experience. Now, interestingly, when talking about the overall menopause experience, participants also described external factors, things like work or social events typical of the midlife, parents aging or increasing care responsibilities. These things really playing a part in their symptom description and meaning making. So the outside world really contributing to how people go around trying to understand what's going on for them. So for some, the perimenopause language really helped make sense of this sense of overload and make sense of pain. Now, I know time is short, so I'm going to go into the second insight quite quickly, which regards healthcare experiences and the difficulty navigating various services and integrating pain and perimenopause care. I like this quote from one participant who went to her healthcare professional to talk about managing her perimenopause symptoms and a new onset of quite worrying widespread pain and joint swelling, and was told, what do you expect? It's menopause not meant to be like walking in daisies, which is a sentence, I guess, that speaks perhaps of the normality of menopause for some people, or for some people's perspective, and also the difficulty and perhaps exasperation of seeing yet another complex case with various symptoms that are difficult to manage within confined clinic times. So the perimenopause and the intersection with chronic pain can also be confusing experience for professionals, I guess, is what that comment is telling us, because they are often faced with complex and unique presentations. But in terms of the healthcare experiences and how they are lived by patients, participants reported a continuum with this idea of symptom confusion, in that it's really difficult to navigate services in which pain and perimenopause are treated separately. So an example came from Lucy and Jane just now, thinking that, you know, in some contexts, pain is seen as perimenopause. In other contexts, it's seen menopause symptoms are seen as features of chronic pain. So the difficulty in gaining access to appropriate knowledge and integrated care is something that's definitely on people's mind. The third and fourth insights here may look like they're somewhat contradicting, in that they juxtapose a sense of resignment, participants saying, oh, I'll just get on with it, with attitudes that are more active. Why should I put up with this? And I don't think that they're mutually exclusive. So while the changes in pain experience brought up by perimenopause are the source of systemic change for some people, Jane was telling us how some people cut down their job hours or take time off work. Others redefine their priorities around the house, or try and manage their symptoms and pace in using social strategies. There's also this sense of having to get on with that, and this not being anything new, and being a learned behavior from experiences earlier in life, gynecological experiences, for example. Within our participant sample, a lot of a high proportion of participants had dysmenorrhea, painful periods, or other forms of gynecological related pain at various points through life that they had to sit out and couldn't allow to affect their daily lives. So this is a learned behavior of working through pain. And one participant reflected on how this affected her healthcare experiences. She'd seen professionals who multiple times had said that she didn't appear to be in very much pain, to which she commented to me saying, well, the thing is that pain or no pain, somebody has to fold the laundry. And these experiences of pain and symptoms being questioned or discredited affect the degree to which pain is accepted by participants in this study and probably patients, which may have an impact on how people participate in pain management interventions. So in summary, I think from these insights, we can conclude that for patients, chronic pain during the perimenopause is very difficult to navigate for a series of personal, social, systemic reasons, and navigating healthcare services can be challenging. So approaches to self-management are influenced by people's previous experiences, especially their gynecological histories. And regardless of the time of onset of pain, the perimenopause experienced as a pain amplifier. So in terms of clinical insights, I guess what patients are looking for is for an effort to lessen the burden of symptoms within the treatments they received, and for less siloed services. I guess in terms of research in this area, my work barely scratches the surface, and we need more studies looking at interventions for this patient group, and also studies that look at long-term outcomes. From a piece of public engagement we did at the start of my PhD, one of the priorities for patients and participants was to increase awareness of perimenopause in pain clinics, musculoskeletal services, and primary care. And we're currently starting a project to develop some training resources for professionals. So really keen to hear from anyone present today if they want to get involved. So I'll, oops, I was going to share my email, but I'm sure you can find me somewhere if you like. And just to thank you all for your time and for listening.
Thank you, Catherine. That's really fascinating work you've been doing. Somebody has just asked, can they have the link to the study? And I believe it's not yet published. Is that correct? So it's still work in progress, really, as we're going on. But I think what is interesting is that the limited research that's been done in this area. There's correlation, and there's the two things happening at the same time. But in terms of answering the question that you posed, which I think is the question, but how, what causes what, and what's the best way of managing these people? We don't have the research answers for that at this time. And it, in a way, we all know chronic pain is a very difficult area to research, and we suffer from that when we're in the clinic. But your last point about raising awareness, helping people to join some of those dots, I think is why we're all here, and why there are 94 people who signed up to spend their evening with us. So it's really fantastic. Thank you both so much. There are a few questions that have come in. This is the more challenging bit in a way, is navigating those questions. There was one, Jane, I wanted to ask, and it speaks to one of the questions that's come in about age. So we've talked about the starting age and when we can expect the perimenopause and menopause to kick in the 45 to 55 average age for the menopause. So, and in a way, in my clinic, fairly comfortable with the up to 60. But then what about the older people? What about, is there an end point to HRT particularly, or to hormone treatment? Is there an age group above which you wouldn't be having these conversations. So I think I'm quite comfortable with the up to 59, 60. Once I get past that, I'm a bit not sure where you're currently at with speaking to people about it.
Yes, yeah. So that has changed significantly. But I think you're not alone, Lucy. I think many practitioners and GPs feel more uncertain about prescribing HRT for women over 60 or 70. And in fact, in September 2020, there was a joint statement issued by the British Menopause Society, International Menopause Society, and the Royal College of Obs and Gynae. And what it said, got it in front of me, there is no arbitrary limits should be placed on the dose or duration of HRT, and care should be individualized. So yeah, what has changed with the advent of increased safety of body identical HRT is that it can now be considered safe for any age group. So in our clinic, with increased awareness, we will see and initiate HRT for women who are 60, 70, 80. And obviously one would start lower dose, of course, but the state of having estrogen deficiency does not go, it continues. And I have met many women in their 60s and 70s who are still getting flushes and sweats. For many women, symptoms will, and we don't really understand why, but the body sort of adjusts to the lack of estrogen. And generally speaking, women will have less symptoms the further on they go in their menopause, but that is not always the case by any stretch of the imagination. But body identical transdermal preparations can safely be used at any age, but of course one would start lower doses to avoid side effects more than anything. So yes, and I've looked after patients who say, you know what, I think my mum could do with some HRT, and so your mum comes to clinic and you know, have had comments like, I'm finally sleeping better, I don't need to be this grumpy, it turns out, and you know, things like that. So yeah, we can be very, very reassured, and yeah, there's no time limit for HRT use is the answer.
Thank you. And no end point, no point at which you have to say, well, I'm too old, I have to stop it now. That it can be
lifelong.
And in a way that relates to your comment about the thyroxine, seeing it as a hormone deficiency.
Yes,
and
yes,
there isn't a point at which you tell people to stop taking their thyroxine, they just keep going. Catherine, I think the next one that's come up is maybe more directed to you. So I'm just going to read it out because it's a long question. How sure are we that this is a relationship of causation and not correlation? And I think the point we've made is that we're talking correlation, not causation. The symptoms described could be understood as allostatic load, which is often greater during the period of life described. Is there evidence of menopause pain symptoms across other cultures which could indicate a shared physiology, or social and cultural triggers which are correlated with normal life cycle processes? So I suppose, is it different in different cultures? And if you've got any knowledge of that area?
Yeah, well, there is the work of a woman called Margaret Locke, who did a comparative analysis of menopause in the United States and Japan. And this is work, I think, from the 80s or 90s. And she described how, from a cultural perspective, menopause is really interpreted differently. So in Japan, the term is konenki, which means midlife change. It has nothing to do with final menstrual period, and is considered more manifestation of life changes as well as bodily changes. It's more about a transition than say hormonal deficiency, as menopause is in our context. And at the time of research, women in Japan were reporting fewer vasomotor symptoms. So things like hot flushes. Now we know that diet is also very important and different within those two cultures. So that might be a factor. And we know that now actually more recent work on menopause symptoms in Japan is showing more vasomotor symptoms. One thing that I've done during my PhD, because I do think that culture is so important, not just in regards to menopause, but also pain and the value that is put on pain, was a secondary analysis of some interviews with women from Mexico City around menopause symptoms, sleep, etc. And pain is rarely mentioned, which we found quite interesting because although, you know, we weren't, in those interviews, they weren't fishing or they weren't probing around pain. It either wasn't thought of as related to the menopause, or pain is considered differently within that social context. And this is a social context where if you have an ache or pain, you don't go to the GP or you don't go to see a healthcare professional because that service isn't provided. So there's different ways of managing one's symptoms and value attributed to various symptoms as well. So yeah, I think it's a great question. I've tried to give you a bit of an answer, but there's a lot more work to be done in terms of comparison of menopause experiences cross-culturally.
Thank you so much. I think that the sort of sense of an area where research hasn't focused and in women, it is an important point, really. There's a couple of questions around testosterone, which might be for either of you. One around trans men on testosterone, and whether they go through the menopause. I don't know if you have any knowledge around that area. So people who are taking testosterone to become more male but are female genetically, whether their experience of menopause is any different, I suppose. Don't know if you see anybody like that, Jane.
I haven't personally, so I would be, yes, I'm afraid my knowledge would be limited. One can only assume that, well, not one can assume, but it would be interesting to know actually if their experience of perimenopause and menopause was different because they would be on testosterone, and so the symptoms that we might attribute it to testosterone deficiency they wouldn't be experiencing. It's a very interesting question, very interesting. And of course, what from clinical experience, some women, it seems, miss their estrogen more, but there's a huge proportion, I think, of women who actually miss their testosterone more. And I've certainly looked after women who are kind of doing okay on their estrogen, and you up the dose a little bit better, but you add in testosterone, and that's the game changer for them for a lot of their symptoms. So that is a clinical scenario we would recognize quite commonly. And other women, you add in testosterone and it really doesn't add an awful lot to symptom relief. So it's very interesting, people's different experience.
There's a comment here. There's some evidence to suggest testosterone deficiency decreases pain sensitivity, and low testosterone being found in some chronic pain conditions such as fibromyalgia. Are either of you aware of that evidence?
I'm afraid.
Catherine, anything
I've come across various bits of literature around testosterone and pain, but I don't think there's a definite answer yet. And I think going back to the trans man question, that's really good and that's a really good question and a really difficult one to answer, especially at a population level, because these like gender identity are not well categorized within population studies, but there are some groups looking at queer experiences of menopause.
Okay, thank you. How do we get involved in raising awareness in pain clinic and MSK setting? I think that's something that I've been doing within my network, and really it's just, for me, it's been about educating myself and understanding the topic, and then talking to people and getting people like Jane to come into our in-service training or our audit days, talking about it, and people and I think there's the questions are out there, and I think we the more we talk about it and the more research comes out, it will be raising it. And then having a bank of places you can signpost people to. There are the very useful, there's the Newson Health Balance website has some useful fact sheets on it. There's various websites. There's the British Menopause Association website, also has references, doesn't it, Jane? I'm hoping you know those are the sorts of areas to be signposting patients to, but also I think it can be useful for other people working in the area to understand a bit more. The course I did was the Confidence in Menopause course, which at the time was free. It's not now, I believe. But doing things like that just increases your knowledge and confidence to be able to, I'm no prescriber of the stuff, and I'm not a menopause expert by any means, but I can have a conversation about it that really helps people feel like you don't just brush off those symptoms, that you can bring them into the conversation. I think, Catherine, that speaks to your finding with people finding it so siloed and separated out. And if you don't know quite what to say about something, you might not go into that conversation quite so readily, I suppose.
And Lucy, can I ask, in your clinical practice, this may be quite relevant, have you begun to see people for follow-ups or that have been able to navigate and discuss their GP and go on to HRT? And have you started to have patients saying, I have noticed some benefit, or are presumably you may not have seen them again yet, but is that something you're beginning to see in small numbers?
In some numbers, absolutely. And certainly, so in one of the clinics where we've been talking about it more, we've been trying to keep a track. We haven't got huge numbers yet, but of the people we've had the conversation with, this is between myself and some of the advanced practice physios who are seeing initial patients, they might raise it as a topic or it comes up, what information they've signposted them to. And then looking back, because that clinic runs on the GP EMIS system as well. So we can see in and see if they've had that conversation. And what we haven't really been able to then close the loop of what difference has that made. Yes, a few anecdotes, and it's all anecdata, isn't it? But certainly like people feeling more like themselves. That's the thing, isn't it? They feel more like themselves, and no one's saying at any point that this is going to fix all of their problems or their chronic pain or anything. But if they're more like themselves, maybe getting some more restful sleep is a common thing.
Cope with the pain. I think that's something I would see quite often. Yes. Yeah.
Absolutely.
Yeah.
And that overwhelm, unable to cope with all the, the middle life where we're caring up, we're caring down, the kids are going to school, and you got all these things, and you're in chronic pain, and then you're not sleeping, and your mood is so flat. At least there's something we can do about that if people do start to. But also, it's important to recognize that this isn't, and HRT isn't the right choice for many people or some people, and it isn't just about pushing the hormones. It is raising the awareness and saying there are other issues. And I think the lifestyle factors are as relevant to pain as they are to menopause. The exercise, the smoking, the alcohol, the healthy diet, subject of another webinar, but are all absolutely as relevant to menopause as they are to pain, and can help both.
Well, I think an important point, I think it's actually a question I just saw pop up, that what's so important or can be very important with HRT, and what can happen very often is patients are started on a dose, quite a low dose, but the dose is not titrated up because the practitioner doesn't feel confident to do that. And that's really really, important if you're going to treat it, that actually, the starting dose of a 50 microgram patch will actually, you would then titrate up to 75 or 100, and that up titration is almost as important as going on the HRT for some women. So I think that's an important point. But I think, yes, that sometimes doesn't happen, which is a real shame.
And I think that's sometimes the conversation that we're having when they come back. They say, well, I spoke to my GP and I started the patch and I'm not much better. And then you, with the small bit of knowledge and knowing that that may be the starting dose and that you do need to go back, and with the one topic for the GP as a GP, you make the appointment to talk about the one thing. Don't go in with everything. And just helping people know how to helping them navigate that relationship with the GP, I think can be very supportive.
I also wanted to add on that topic that while HRT might not help with pain directly, it might not be useful for everyone's pain. If we start seeing pain and perimenopause symptoms as a phenomenon, they might help with it might help with other symptoms and lessen the burden on patients, and it might make pain easier to manage, which is also a gain. But maybe we're not measuring the right things when we're looking for these differences.
In my experience, and obviously I'm seeing the perimenopause, menopause as the primary, I haven't got figures, but many women report improvement in joint aches and pains specifically. Now, clearly, these are women, many of whom don't have chronic widespread pain or fibromyalgia, but some of them have had, and so there I have, no doubt that it has the potential to help with all manner of pain, and presumably somebody with chronic pain who then has additional soft tissue related pain or joint pain, that if you can get rid of the bit that's the more recent pain, that makes the chronic pain more manageable, etc. Yeah, that's an observation I would certainly make.
Thank you. Oh yes, burning mouth syndrome. Now, Jane, you mentioned burning mouth, and there's somebody. This thing. It keeps jumping around. That's the problem. I've seen a number of women in their 60s and 70s who get burning mouth, who've never had anything before, and get really distressed to the point of suicide, and are really difficult to treat. Would it be worth trying HRT?
I would say yes, because it is safe. I'm not aware of any studies in this specific area, but I think that where we are now is that because we have a safe version of HRT to offer, there's almost nothing to lose, is there? But it's having that conversation, informing them, and some women, I guess, would be open to it, some women wouldn't. But I can certainly think of women I've looked after who have had burning mouth as one of their symptoms, and it has improved. And so I think, because it is a safe option, whether you're 50, 60, 70, 80, it would be worth trying. And I think it's difficult. I think this bit is difficult because many GPs have not had the time or not been able to update their knowledge, and so may be fearful of starting HRT for someone who's 60 or 70. But that, we talked about that before, didn't we?
And I think for those people, sometimes it's worth making your links with your local community gynae menopause clinic to be able to support those people. Maybe not if their GPs are struggling with that, then. But also, I wonder if you go to the facial pain clinic and talk about your burning mouth, unless you're thinking of it, could this be a presentation of the perimenopause or menopause? You might not ask any of the other questions about the menopause, so that wouldn't be linked together.
Yes.
And I think it would be difficult to signpost a patient to go and talk to their GP about HRT for their burning mouth. But if you then have picked up that they're also postmenopausal or having perimenopause, plus their sleep disturbance, plus their some of the
And they are
other
having hot
symptoms.
flushes. Yes, they are having
And they
hot
are having hot flushes.
Yes, and
And
vaginal
could
dryness.
actually this be part of the constellation of the symptoms that you're seeing? The way to find out if it is, and if it is amenable to any support in that way, is try it.
Yes, and that's the thing with HRT. We always say you can try it and then you can stop it again. If it doesn't, providing you've titrated the dose to a sufficient level, of course you can absolutely start it and then stop it again. That's very reasonable.
There's somebody on who's a PhD student at UCL studying interventions for chronic pain in menopause. Welcome. I was wondering if it's seen in clinical practice that analgesics are prescribed to women of menopausal age with chronic pains. Analgesics are prescribed for people with chronic pain, and there are lots of them with menopausal age. So I suppose there is crossover. And whether you, for the sort of aches and pains that I may have slightly misunderstood the question, but any thoughts on that, Catherine?
There's a study by Caroline Gibson et al. Again from 2020, I think, that looks at frequencies of opioid prescription in perimenopause females with chronic pain, which might be interesting for you. And it seems like it's again a veteran population. It seems like there's higher levels of opioid prescriptions within the perimenopause chronic pain group. Again, study from the States, but some evidence there.
Thank you. Some literature would indicate that progesterone and testosterone have a protective role in fibromyalgia pain sensitivity. Progesterone and testosterone being protective, and we're missing them in the perimenopause. How about antidepressants during the menopause and pain management? Any other strategies that could be implemented instead, or that you've noticed in your practice that starting HRT can make a significant change in mood? And I know that in the past, things like venlafaxine were very often used. Am I right in saying venlafaxine for menopause management?
Yes, yeah, and we actually at Use and Health, they are doing some work about, there's some research going on about the use of antidepressants, and people are asked at first clinic, are you on an antidepressant? And then at subsequent follow-ups are being asked, have you stopped or reduced your antidepressant? So it's a huge area of, and I think there's two elements to that. People are often offered antidepressants for the anxiety and low mood associated with perimenopause and menopause. And then there are women, such as women who've had estrogen receptor positive breast cancer, who may choose not to go onto HRT, who are then offered SSRIs such as venlafaxine for symptom relief. So there's sort of two parts to that, really. But and of course, there will always be women who are perimenopausal or menopausal plus minus chronic pain who develop an anxiety or depressive illness concurrently, and the use of antidepressants may be appropriate, of course, but to be offered antidepressants first line for your perimenopausal symptoms is that is covered in the NICE guidance, that actually it is more appropriate to be offered HRT for the root source of the symptoms. But of course, there's huge overlap. We could be having this webinar on a psychiatry forum, I think, couldn't we? There would be a huge overlap of symptoms between depression, anxiety, and also pain and menopause.
That makes me think about raising awareness, and you can come and do this talk for the rheumatology clinic and probably the gastro clinic. We haven't touched on gastrointestinal symptoms, and yes, the psychiatry teams,
yes,
yeah, and the cardiology, and yeah, it's a multi-system thing, isn't it?
Yeah.
Sorry, go on.
I think there is more awareness about, yes, how many different bodily symptoms, that bodily systems can be affected.
Impacted.
And reflux is something, and that's relevant also for people using NSAIDs for chronic pain. Reflux is a really common perimenopausal symptom, and sort of who knew, but yeah, that is very common.
How about approaching a conversation with a patient who's on the contraceptive or have a coil, so they're not having periods, and so they don't know if they're perimenopausal? What's the comments on that?
They wouldn't know from the lack of periods, but of course, particularly with, say, a copper coil that hasn't got any hormone, or indeed a Mirena coil, which would just have the progestogen, they are likely to get symptoms from the estrogen deficiency, of course. And so we would expect those women to present in a very similar way, minus the period changes. Contraceptive pill is different. Of course, certainly the combined oral contraceptive pill can mask very well perimenopausal symptoms. But of course, most women by 45 to 50 are being encouraged to stop their combined pill because of it being an oral synthetic estrogen. And so many women will stop the combined pill and then suddenly realize, yes, that they are actually having quite a lot of symptoms. Progesterone only pill obviously is often used, nearer 50 but again, that will really only mask period changes and menorrhagia and things. They're likely to still get their estrogen and testosterone deficiency symptoms because they're only on progesterone.
There is a question about phytoestrogens and soya products. Any comments, Jane? Safety and helpfulness.
Yes, thought to be safe, but often ineffective would be the quick answer to that question, because the dose of soya you need to ingest to replicate using some low dose HRT, is incomparable. Yeah, but certainly early, there are some women who do find it beneficial, but I think it would tend to be for milder symptoms. But yes, certainly would be viewed as safe. But again, I don't know if there's, I'm sure there are, but I can't bring to hand a study comparing those two.
There is a question about separating out if somebody is fibromyalgia or menopause, and how we decide which we treat. Are you saying we should treat them with HRT and see if they improve? That would mean putting lots of people on HRT and costing the NHS lots of money, possibly without really focusing on those for whom it is the necessary treatment. What's the NNT for HRT to manage people's pain? I think clearly the research isn't there in terms of finding NNTs, and it's not necessarily using HRT to treat pain. It's to treat the menopause as a whole. Catherine, any thoughts on that question?
It's a really good question, and one that I started off wanting to answer when I started my PhD, but more and more I wonder if that's the right way of looking at things. I wonder if it is about trying to define where one condition starts and the other one ends, and if it's not more about trying to treat patients holistically and understanding that it might be fibromyalgia and perimenopause, and you might need to try different things and see what works for the individual. I think it's really key to think about how individual a lot of these experiences are, and how some people might have one symptom and not the other. Some people might have some tendinopathies on top of more widespread, more centrally driven pain. There's a lot going on, and I think having awareness that there is crossover between those conditions for now is probably the most useful thing for clinicians, so that we can start thinking about strategies and trying different things.
And I think it would come back to possibly making the suggestion that there would be nothing to be lost from trying body identical HRT. And I've had the whole range. So I've had women who've been diagnosed with fibromyalgia who haven't felt that HRT has helped with that specific symptom, but perhaps has helped with other symptoms. And I've certainly had women who come back and said, I don't think I ever had fibromyalgia. I think what I had was perimenopause, because all that pain has gone. Now, these, again, I'm seeing a very different population of patients, very clear about that. But I think the range of experience with people's pain and HRT is quite varied. But for some women, it's really quite powerful, the benefits. And as I say, I've had a number of patients say, I actually don't think I did ever have fibromyalgia. I think I was misdiagnosed. But it's just hugely, and that's the thing, isn't it? Individualizing patient care. But of course, with the resources and time, it's incredibly difficult within our healthcare system.
Yes, and I think that there's a whole separate question in a way about resource management. And I am going to do one more question, and then I think it's 8 o'clock and we should be thinking about wrapping up. How long, Jane, do you trial someone on HRT before stopping if there's no response despite up titration? So I suppose that you can start it, you up titrate, symptoms haven't changed. How long do you give it before you say that's the situation?
Yeah, I mean, I think you'd want, if they're not getting side effects, I think you would safely, go up to the maximum dose of 4 pumps of gel or 100 microgram patch. We, as an aside, we sometimes do off-label higher doses than that, but in this context, and I think you'd want someone to have been on a dose for a good 2 to 3 months minimum, really. Testosterone takes much longer. Testosterone, really, you need to be looking at on each dose a sort of trial of 3 to 6 months. It can be much slower. But yeah, I think if somebody's been on sort of a maximum dose for a good 3 months, 4 months of that estrogen dose, then I think you could then say, well, that's not been effective. But of course, it may have been effective for their other symptoms, but not the pain. And they may say, well, actually, I've had other benefits, I'm going to stay on it, but it hasn't actually helped my pain. Again,
but there's also, isn't there sometimes an issue with absorption?
Yes.
So that might be, and we haven't touched on blood tests for menopause diagnosis at all.
Yes.
But
that's a really good point, Lucy. I, in fact, saw a woman in clinic today who had up titrated gel, and the minute she swapped to patch, she said it was like just a huge turnaround. Within days, she got benefits. So we don't know why, but there are some women who absorb better from patches, some women absorb better by gel, and some women absorb better by Lenzetto spray. So very good point. I should have said that. As well as changing dose, you would probably want to do at least one change from gel to patch or patch to gel, because it can vary enormously. Yeah, very good point, Lucy. And my brain is a tire. That's rubbish.
We're all coming to the end. I think there was sometimes people come and say, my doctor did blood test and they tell me I'm not perimenopausal. And that you don't need the blood test to test for the menopause, but you might use a blood test to rule other things out.
Absolutely.
Sometimes blood tests are used to assess levels.
In the perimenopause, estradiol is very, very unhelpful because it's so fluctuating. If we think back to the graph, you might pick a day when estradiol was high, you might pick a day when estradiol was low. And so in the perimenopause, it is not helpful at all to aid diagnosis. One category would be the women under the age of 40 whose periods have stopped. Then you would use that as part of diagnosis and an FSH. And equally, women who are firmly menopausal and on HRT, we might use an estradiol to monitor exactly whether they are absorbing, but that would be women that are firmly menopausal, not perimenopausal. And then estradiol becomes more reliable again.
Okay, fantastic. Thank you both so much for your hard work and helping me put this on and stepping up to it. It's just been brilliant. I think the questions show that there's a real engagement in this. A reminder that the email with the recording link will come out to everybody with the evaluation form, and then you get the attendance certificate, and you can listen to us wibble on again if you wanted to go on the YouTube channel. So thank you, and thank you to the British Pain Society for hosting us, and for giving us the opportunity to raise this awareness. I think more to come. All right. Thank you so much.
Thanks, Lucy.
Thank you.